So I am with Xperia Health, and I'm really proud to be part of this conference that has e-patients featured, because what we do at Xperia Health is redesign healthcare to help reconnect with patients and families. We're focused on patient experience in healthcare, and the reason why we bring design thinking to it is that what we saw in doing this work is that so many of our hospitals and healthcare systems, who are now being linked to reimbursement related to patient satisfaction, thought that patient experience was about improving valet service and having really nice gift shops. So the focus of our work is really about the reason why people come to healthcare organizations is to receive healthcare. And if you do not redesign the way that care is delivered to create connection with patients and families and to restore purpose to doctors and nurses, then you're really not going to change the experience. So I'm going to start out by saying I'm the biggest fraud on this panel. I am not formally classically trained in design. I am actually a Lean Six Sigma Master Black Belt. I spent my first 10 years of my career at the General Electric company, stripping out waste, increasing efficiency, getting rid of defects. I was super efficient. And then I was running customer loyalty programs. And what I was finding in doing my work was that I spent a lot of time crunching data, doing Six Sigma statistical analysis of sales processes. And the salespeople always told me, I looked at which salespeople win and lose deals and why. And they'd say, the reason we lose deals is because we have bad products and poor pricing. And the reason we win is because of relationship every time. And I thought, that's the biggest load. I mean, how can it always be relationship when you win and always somebody else's fault when you lose? So I did my rigorous statistical analysis, and what I found was the only thing I could actually link to whether or not salespeople won or lost deals was relationships. Those salespeople who followed up quickly with their clients after having an initial discussion and had discussions with them about the proposal soon won, and those who did not lost. That was the only thing I could prove out. So I continued on my journey. I was running customer loyalty programs at GE, and then I started a consultancy that took me to the Cleveland Clinic, where I met this woman, Dr. Bridget Duffy, who had been named the Chief Experience Officer of the Cleveland Clinic. And I came in to help her improve experience by stripping out waste and increasing efficiency again. And she looked at me cross-eyed and said, "Are you kidding me? You can have the most efficient processes in the world. Guess what? That's not going to change the experience necessarily." So she has since become my mentor, and I learned a little something about restoring humanity in healthcare. She and I started this company together about 3 years ago, and have spent some time in the trenches with patients and families and doctors and nurses since then to design interventions that enable people to build relationships in healthcare. So, because what we're seeing is, when we talk to doctors and nurses, we hear the same thing again and again. Doctors and nurses didn't get into healthcare to treat people badly. It's not like they're trying to create a bad experience. It's that they have become checklist fatigued. You have this list of all the things you have to do for quality and safety and financial performance, and you have 15 minutes to execute on it, so you better make it happen snappy. And because of that, they're experiencing burnout and compassion fatigue, and they don't have the capacity within them to connect with patients. So this is one heart surgeon that we spoke to who said, "We're increasingly feeling like assembly line workers. That's okay for my car. It doesn't notice. It has no experience." And then the advent of medical technology. So many people here have such really cool technologies. And this is actually a real paper chart printed from an EMR next to a paper chart from 2001. We think we're making processes so much more efficient and improved by layering in technology. And there's no wonder that everybody who is practicing medicine today has such a crazy aversion to it. One doctor said to me, "I used to look my patients in the eye, now I look my computer in the eye." It's really hard to have a meaningful discussion with a patient and get into why they are not being compliant with their medications if you're not even looking them in the face. So I've changed my thinking. So I started with designing for efficiency. We have to do this in healthcare. We all know we have a really broken healthcare system that costs are astronomical. And so it's really, really important to be more efficient. It's important. People don't want to wait for 8 hours in an emergency room. We have to take care of that. However, if you only solve for efficiency, what we have found is that you're missing a huge, huge opportunity. And so the work that we do is really about restoring human connection and empathy in healthcare, and creating the opportunities to do that without actually adding to doctors' and nurses' plates. Because for us, we find that you have to combine these disciplines, that my lean background is great, but if I don't actually create an opportunity, I can be really, really, really fast at getting you in to see a physician. But if that physician doesn't actually listen to you or explain to you effectively, you have still had a horrible experience. In fact, there is data that shows that there are emergency rooms with 0 wait time and really, really, really poor patient satisfaction. And there are emergency rooms who have 8-hour waits, who have patient satisfaction through the roof. And the difference is how that patient is communicated with while they're waiting. So how do you do this in a healthcare system? We spend a lot of time doing what many people would do in the design thinking field, and I pretend I know how to do it. We map the gaps. We take a look at the experience from first impression to last impression and the care coordination in the middle. And you find just the most basic things. Often our first impression in healthcare is somebody who's got a checklist that there's a burnout, apathetic person at the front desk. It's not necessarily their fault, but we have this story of one patient who came in, an 89-year-old man, 1 year post-op, walks into a brand new heart center. It was gorgeous, beautiful, rolls up in his chair. He's with his daughter, who is a surgeon, and he says, "Oh no, it's her again." He is terrified to approach the front desk because this person behind the desk has created such a bad experience for them. So how do you redesign that first impression so that it's a little bit different? And we'll talk about that in a minute. We spend a lot of time walking in the shoes, not just with patients and families, with staff. And it's so often that we find these mavericks within organizations that have these little pearls of wisdom and the things that they're doing differently that we can amplify and spread throughout the organization quickly. Doing this, we actually came across one particular pharmacist in an organization, and he could tell in the electronic medical record the first time a patient was receiving a dose of chemotherapy. And instead of treating that patient just like any other patient who walks through the door and handing a bag across the counter and say, "Thank you very much, ma'am," he changed his practice. He saw that that was a fragile, newly diagnosed patient, and he would come out from around the counter, he would sit down with that man or woman, look them in the eye, ask them what their fears and concerns are about taking that medication, and see what it was that he could do to help address them. Nobody knew. This was a lone pharmacist. This wasn't the manager, the leader in the organization. This was one person who was changing the way that those patients were receiving care. Overnight, that became a standard of care in that organization where every single pharmacist had this practice embedded and redesigned the way that they were delivering that experience to patients and families. Through that process, we also found a practice called Code Lavender. Code Lavender is something that came out of a hospital in rural Hawaii. This hospital had a housekeeping staff with the highest patient satisfaction scores on record, and nobody knew what they were doing. And what we found was that actually those housekeeping staff, before they left a patient room after cleaning it, they would turn to the patient and they'd say, "Is there anything else I can do?" And unbeknownst to anybody, over half the patients in that hospital were saying, "Yes, could you pray with me?" So overnight, that hospital, they actually called it Patient Lavender, implemented a standard where over the loudspeaker they would call out Patient Lavender in room 303, and everyone in the hospital would stop and send healing intention and prayer to a patient in room 303. We took that practice to the Cleveland Clinic, where we put an actual rapid response team around it of holistic nursing, social work, pastoral care, wellness, and other resources. And we're dispatching this to support people's emotional and spiritual well-being. And what we found one day was a nurse called down from a pediatric unit. They had just taken three children off of life support. And she said, "Can I call Code Lavender for the staff?" We are a wreck. These kids have been with us for a month. We know them, we know their family. We have to turn around and treat the next patient. Well, no wonder you can't provide a great experience. Are you kidding me? If you just survived a basic death in the family, now you have to go around and just pretend it didn't happen. I always tell people when I was at General Electric, if that happened in my work environment, we'd have called in crisis counseling. You know, you would have resources come to help support people if you had something so traumatic happen in your day. The healthcare workforce is supposed to turn around and just keep moving. So we have created this and packaged it, and it's one of the tools we just give out to people, and we're seeing healthcare organizations across the country adopt this, take it, and spread it. And now we're even seeing it embedded with technology so that it's hardwired through workflow communications tools so that anytime you call a code blue to resuscitate the heart and lungs, you send out a code lavender to resuscitate the spirit. We're also listening to patient and family voices in this redesign process. This is actually an interesting company that we are using called WeGo Health. WeGo aggregates people who they call patient activists from around the country. So if our e-patients aren't all members yet, you should all be. But WeGo helps us when we bring together groups to amplify the voice of patients and families. They can pull together a group of diabetes patients, Crohn's disease patients, whatever the rare disease is, to help you figure out from the voice of patient and family what is happening. We have hospitals who are coming around this from across the country who are forward-thinking strategically about how they change the game and actually innovate around the patient experience. And we brought them together to redesign the discharge process. And I'm starting out, discharge, really? Is that a really pleasant name to call leaving the hospital? We had one patient who called it, I think, taking leave. But I think, you hear these powerful things from the voice of patients and families. This patient who had been in and out of the hospital several times said, when you enter the hospital, you lose control. Leaving the hospital is about getting it back. So it helps you really reframe the dialogue around discharge. And so what does it mean to send somebody home with control over their life? That doesn't mean that you send them home fearful, uncertain, put them in the back of a Mini Cooper with a broken leg that's immobilized. So we hold these design sessions to redesign and bring together, because what we're hoping to do is to be able to put some science behind the human experience of care. We've actually partnered with Stanford's Cirque Center of Research Excellence to help demonstrate that if you restore human connection in healthcare, you also improve healthcare outcomes, patient safety, and financial performance. And what we're also, through these processes, we've discovered things like organizations who are putting in place informed hope. Shame on us that right before in a procedure, we take a patient through the list of all the things that can go wrong. Please sign here, you may die. Now I'm going to put you to sleep. Thank you for your peace of mind. So what organizations are putting in place informed hope and changing the checklist on the medical record technology so that we're giving patients hope for how they can better heal after their surgical procedures. We've created a sacred moment. It's not that fault of that person who is the first experience in healthcare that they are not necessarily creating the best first impression. We've put so much on their plate. So one organization we've worked with has put in place a sacred moment upon admission. Others are calling it a sacred moment upon arrival, where physicians and nurses, rather than just going through medical reconciliation and checking to make sure that they've got the right armband when they walk in the room, they're asking patients first, what is your greatest concern that I can address for you today? They're not backpedaling, making sure that they're checking off the box and getting rid of all of the different things that they're required to do, but actually taking a moment to first connect with patients. And what we're hearing back from the physicians and nurses who are doing this is that They were totally scared at first. They thought, oh my gosh, I'm never going to be able to accomplish my visit in 15 minutes if I ask them and let them start talking, particularly some of those lovely elderly women who come through here, who are so lonely. And what in fact is happening is they're having fewer interruptions in their day, because patients don't have to call back to get the answer to the question that didn't happen in their visit in the first place. So now they're wiring this into the EMR and changing it. Some clinics that I've been working with through the California Healthcare Foundation actually are putting this into the sticky notes in their EMR so that the person who is at the front desk can ask, what is your concern that you would like the physician to address today? That's going back then to the physician who says, I hear you want this to happen. Is your greatest fear that you're here for today? And it's changing the dialogue. They're discovering things that prohibited patients from being compliant with their medications and able to change their engagement and their compliance. Who's seen this before? Okay, so this is the Domino's pizza tracker. I suspect people maybe are a little bit snobby about pizza here. I am personally. However, I am fascinated by the Domino's pizza tracker. I can order a pizza online. I know where it is every single minute. I know when it's being prepped. I know when it's in the oven, when it's in the box, and oh my, it's out for delivery. It could be here any moment now. I can get a piece of tissue taken out of my body and wait in fear for 2 weeks with no update. In fact, if it comes back negative, which by the way, if I am not a physician or nurse, I may think negative doesn't mean such a positive thing, that you may not even bother to call me. I'm just supposed to assume that everything's okay if I don't hear from you. Why aren't we designing technology in healthcare that enables people to see where they are in their process? We have an organization that we've been working with in our rural community who's trying to say, why is it that after an abnormal mammogram, we have to wait 2 weeks for a breast biopsy? Why can't it happen that same day? Imagine the fear and anxiety of that woman waiting at home for over 2 weeks for something to happen and to hear back. And we do nothing to keep her connected to somebody within our organizations. So we're creating technologies that enable us to connect beyond the hospital walls and to actually share information and updates with patients and, almost more importantly, their family members. It is shocking, actually, to see that these technologies we're designing so often need to be designed for the caregivers who are often left out of the equation. And so this is an example of, often we have far-flung family members. They want to know what's happening to their patient or family member while they are in a hospital. And you're dependent on perhaps the one family member who can be there, or hopeful that as you wait for 8 hours in the hospital, you'll just happen to be there when that hospitalist rounds on your family member. Unlikely, but maybe you might be there at the right time, or if you actually leave to go get a sandwich or go to the bathroom, you might miss a window of opportunity. So how do you implement technologies where when that physician or nurse is at the bedside communicating to a patient who is probably not fully present, that you're capturing it, recording it by voice, taking pictures, taking video, enabling those care instructions to be sent to the people in their lives who are actually going to be in charge for caring for them after they leave the physical building. So this is the work that we've been doing and how we're trying to change the checklist in healthcare. As we think about designing human connection into the checklist in healthcare, we try to make sure that whatever we're doing and when we're working with organizations, that we're taking something off of staff and physicians' plates. We have such a burnout workforce in healthcare, and so often we go into things with such good intentions, but if it adds work to the teams, one, you'll just never get it actually adopted, but you're just going to contribute more to making it a bad patient experience for everyone. We think that the greatest innovation in healthcare is going to come from addressing emotional and spiritual needs. Healthcare is a very vulnerable experience. And so as we look at designing processes and technologies and working with healthcare organizations, one of the things that's always on the checklist is verifying that somehow this is getting at some core fundamental need that creates a strong, powerful emotional response. You've got to integrate patient and family voice. I mean, healthcare, and at least in academic medical centers and most healthcare organizations, we are a little bit behind the game at actually realizing that you can't design something without customers involved. In fact, we're scared to death to have patients and families in the room because, oh my gosh, they're going to see how broken we are, and they're going to tell people, oh my gosh, what if Joint Commission comes? We have to have such lengthy discussions with healthcare organizations to get them to let patients in. Enabling communication beyond the hospital walls, it's really tough, and most people in this room are probably far beyond this as a bullet point. However, most healthcare organizations are not. They think that medicine is what happens within the four walls of the hospital, when the vast majority of a patient's journey is happening in their home or in other interactions. And finally, we just think it's really critical that you put human connection on the checklist. We are seeing more and more that it's just about completing we're checklisted out in healthcare. So if human connection is on the checklist, then we're failing our patients and families. So thank you very much. Honored to have the opportunity to speak here today.